but soon thereafter. All right, why don't we start? I'm Scott Podolsky, and I work with Carol Benoit and Jen Pusetti to organize the regular Department of Global Health and Social Medicine seminar series. We're thrilled this spring to host several seminars devoted to the health of indigenous peoples. And for this, we're grateful for the wisdom and input of our colleague, Joe Gahn. I'll get to introduce Professor Gahn himself, and he'll have the honor of introducing today's speaker, Professor Donald Warne. Joseph Gahn is Professor of Global Health and Social Medicine in our department and Professor of Anthropology in the Faculty of Arts and Sciences in Cambridge. He's collaborated for 25 years with American Indian and other indigenous communities to rethink community-based mental health services and to harness traditional culture and spirituality for advancing indigenous well-being. He's an enrolled member of the Oglala Tribal Nation of Montana, and among many other roles, is the director of the Harvard University Native American Program. And he'll have the honor of introducing Dr. Warne. My job is to remind you all to submit your questions via the question and answer feature on your screen for discussion at the end. So, Professor Gahn, on to you.
Thank you, Scott. I so appreciate that, and welcome everyone to our event today. I'm going to ask your forbearance as we begin for just a few extra minute or two to do a more detailed introduction, because it's not just an introduction to our speaker here today, but also to kind of a new speaker series that we're inaugurating, kicking off today with this event. Scott already introduced you to me. I'm a psychologist by training. I studied the intersection of culture, coloniality, and mental health. And I arrived at Harvard 2.5 years ago, where I have this joint appointment in anthropology and in global health and social medicine. I am the faculty director of the Harvard University Native American Program just for the past 1.5 years, and an enrolled member of the Oglala Tribal Nation of Montana. It's really a pleasure to welcome you to this event on behalf of the Harvard University Native American Program and on behalf of my colleagues here in global health and social medicine. The Native American Program, or HUNAP as we refer to it, is going through its 50th anniversary this year. So we're doing a number of events to commemorate that. What's important to know about HUNAP and Harvard is that the Harvard Charter of 1650, which really still is the governing document of this university, committed Harvard to the education of English and Indian youth back those centuries ago. And so it continues to observe aspects of that commitment. HUNAP is one expression of that. HUNAP has a fourfold mission. It really is trying to promote education, community, scholarship, and inclusion. We have about 240 students across campus who identify as indigenous. And in fact, in 2018, we celebrated the arrival of 4 new Native American, indigenous, or indigenous studies faculty members. So there's a lot happening these days, in part, which is how this seminar series has arrived as well. This is a new Indigenous Health Seminar series that we initially tried to host a year ago, a joint effort between HUNAP and the Department of Global Health and Social Medicine. We had originally planned to have in-person gatherings with a dinner and a presentation and some exchange and discussion. Obviously, the pandemic has derailed that. So we've temporarily folded this inaugural effort into our usual Global Health and Social Medicine departmental seminar series. And I'm really grateful to my colleagues and the staff of our department for supporting today's event, so thank you. Let me start by acknowledging the people who have hosted this traditional territory for a long time. Harvard Medical School is situated in the traditional territory of the Massachusetts people. We try to make sure that at all of our events here at Harvard that HUNAP's involved with, we acknowledge the traditional stewards and people who customarily occupied this territory. There are some of you today who are joining us who are not usual attendees of our seminar. So let me just give you the structure briefly. We'll do an introduction to Don Warne, our speaker. Then we'll hear from Don for his presentation, and then we'll move into an audience exchange featuring questions and answers. And I'm thanking Scott again for that period where he will help to route your written questions through the Q&A function to us so that we can get those questions to Don and hear his responses. Now, Scott also told you a little bit about Don already. It's my honor to introduce Don Warne as our inaugural speaker for this Indigenous Health Seminar. Don is the Associate Dean of Diversity, Equity, Inclusion, the Director of the Indians in the Medicine and Public Health Programs, and a Professor of Family and Community Medicine at the School of Medicine and Health Sciences at the University of North Dakota. Don has his MD from Stanford University School of Medicine in 1995, and an MPH from Harvard School of Public Health in 2002. And we're so proud to call him a HUNAP alumni. He's an enrolled member of the Oglala Lakota tribe from Pine Ridge in South Dakota. He comes from a long line of traditional healers and medicine men himself. He's also serves as a senior policy advisor to the Great Plains Tribal Leaders Health Board in Rapid City, South Dakota. And importantly, he recently initiated with colleagues there at UND a new PhD program in indigenous health, which is the first of its kind in the United States. He's published dozens of articles and chapters on these topics. He lectures internationally, so we're really delighted to have him. Formerly, he's been a primary care physician with the Gila River Healthcare Corporation in Arizona, a staff clinician with the National Institutes of Health. He's been on faculty of public health at North Dakota State University, on faculty of the Indian Legal Program at the Sandra Day O'Connor College of Law at Arizona State, and executive director of the Great Plains Tribal Chairmen's Health Board. I first encountered Don around 1999, I think it was, at Dartmouth College, where I was a fellow. He came and gave a talk there in the Dartmouth Hitchcock Medical Center. And I most remember then that Don reviewed the traditional medicine wheel, was talking about how biomedicine might interface with the medicine wheel when it came to services and outreach to American Indian communities. And so I've been obviously excited by that work and following Don ever since. Most recently, he and I worked together with some other colleagues to organize the 2019 Traditional Medicine Summit, a gathering of traditional healers from Indian communities that was sponsored by the NIH's Tribal Health Research Office. In short, Don really perfectly bridges academy and community in service to Native people. And so I'm delighted that Don is our inaugural speaker for the HUNAP Global Health and Social Medicine Indigenous Health Seminar Series. The title of Don's talk today is The Impact of Unresolved Trauma on American Indian Health Equity. And so now let me please turn the floor over to Don to hear what he has to share with us. Please, Don.
Well, thank you so much, Joe. I really appreciate the opportunity to speak with you and the group from Harvard, and looks like about 500 participants in the webinar today. And I agree that we have so many things in common and a lot of areas of work that we've done together over the years. And I feel excited about the future, particularly with the young scholars coming up. And we have so many people who are focusing on the needs of Indigenous peoples from a health perspective, but also from economic perspective, legal perspective, community development perspective. But I think it's also important to understand where we come from and why is it that we have such challenges today. So I'll go and share my screen and provide a presentation focusing, like Dr. Gunn mentioned, on the impact of unresolved trauma on American Indian health equity. And I think it's important to also really identify what these terms mean. You know, what is unresolved trauma? Who are American Indians? And what is health equity? And how might we move forward in a positive direction to try to improve health outcomes? So I really appreciated starting this with the land acknowledgement for the original inhabitants of the area where Harvard is now located in Massachusetts. I'm very proud of our university at the University of North Dakota. Just in the last year, we've established a formal land acknowledgement for UND. So very briefly, today the University of North Dakota rests on the ancestral lands of the Pembina and Red Lake bands of Ojibwe and the Dakota Oyate, presently existing as composite parts of the Red Lake, Turtle Mountain, White Earth bands, and the Dakota tribes of Minnesota and North Dakota. We recognize that the people who have resided here for generations and recognize that the spirit of the Ojibwe and Oyate people permeates this land. As a university community, we will continue to build upon our relations with the First Nations of the state of North Dakota, the Mandan Hidatsa Arikara Nation, Sisseton Wahpeton Oyate, Spirit Lake Nation, Standing Rock Sioux Tribe, and Turtle Mountain Band of Chippewa Indians. So it's important to acknowledge that every part of this nation is occupied land of Indigenous peoples. And throughout Canada, I think they've done a very good job at land acknowledgements and recognizing the importance of Indigenous peoples. And we're starting to see that move forward here in the United States. Very happy to see that. Well, I'd like to start these discussions with some just definitions. Who are we talking about when we say American Indian? And the legal definition for the race is American Indian and Alaska Native. And at the federal level, it's actually the Office of Management and Budget who determines the races and ethnicities that are recognized in the United States. Why it's OMB, I have no idea, but it's Office of Management and Budget that actually designates the recognized races and ethnicities. So in addition to American Indian, Alaska Native, of course, there's the white population, Black or African American population, Pacific Islanders, and Asian Americans. Those are the 5 races. And then there's one ethnicity that's recognized, and that's Hispanic. So that's why we have the term non-Hispanic white. So Hispanic's not a race, it's an ethnicity, and then the other 5 designations are races. So why is it American Indian and Alaska Native? Well, in Alaska, they do have indigenous people who are culturally very similar to American Indians. For example, the Athabascan groups in central Alaska are very similar even to Navajo and Apache tribes that we find in the southwestern part of the United States. So Athabascans are American Indian culturally. But if you look at the northern part of Alaska, the Inuit communities, actually they're in northern Alaska, but also northern Siberia, northern Canada, and Greenland. So they are a circumpolar indigenous group, but they are not American Indian, even though they are indigenous. Also, if you look at the Aleutian Islands, the island chain that goes out into the northern Pacific, culturally, they're much more similar to Pacific Islanders because they are Pacific Islanders, but just in the northern Pacific Ocean. So that's why it's called American Indian and Alaska Native. I identify myself as American Indian because I'm not Alaska Native, even though legally I'm American Indian and Alaska Native. So just to look at some of the terminology. So within the population of American Indians and Alaska Natives, we have a political designation, being an enrolled tribal member. So we have over 570 federally recognized tribes of American Indians and Alaska Natives in the United States. And people who self-identify as American Indian and Alaska Native may or may not be enrolled in their tribe. So I'm an enrolled tribal member at the Oglala Lakota Nation in Pine Ridge, South Dakota. But not every American Indian Alaska Native is an enrolled tribal member. So we also have to be careful when we're looking at data sets. If we're talking about census data, that's people who are self-identifying as American Indian or Alaska Native, but the Indian Health Service data does not include all people who identify as AIAN. So we have to be careful in terms of exactly what population we're talking about. We also hear the term Native American used interchangeably with American Indian, but actually Native American as a term is also legally defined. There was what was called the Native American Programs Act in 1978. They defined Native Americans as American Indians and Alaska Natives, but also Native Hawaiians and indigenous peoples of US territories in the Pacific Ocean. So American Samoans are Native American legally, and the Chamorro indigenous groups in Guam are also Native American along with Native Hawaiians. So I try to be more specific in terms of the populations I'm talking about. And if we're saying Native American, we're being inclusive of other indigenous groups to US territories and Hawaii. So I've heard over the many years kind of arguments, which is the better term, American Indian or Native American? And people don't like American Indian because the source of that term is actually Christopher Columbus thought that he was in India. So that's why we became American Indians. So it's really ironic. The reason there's an Indian Health Service and a Bureau of Indian Affairs and Indian tribes is because Columbus was lost at sea and thought that he was in India. So I've heard people say they prefer Native American. But even if we look at the term American, that comes from Amerigo Vespucci, who was also an Italian explorer. And he named the continent after himself. So that's why we have America, is because of that Italian explorer. So I look at it when we're kind of having that discussion about which term is better, American Indian or Native American. In many ways, we're arguing about which Italian explorer do we want to pay homage to? Is it Columbus or Vespucci, essentially? So the term that I've been using more frequently now is indigenous. And indigenous is a much more encompassing term. It includes Native Americans, but also indigenous populations around the world. And when we look at the history of human migration and where we come from, we know that historically, through DNA evidence anyway, that human life started out of Africa. And that was between 1 and 2 million years ago. But over the last 10,000 to 100,000 years, people have been migrating across the globe. So the original inhabitants of each part of the earth are the indigenous peoples. So the original people in those various parts of the earth are the indigenous peoples. And then over the last several hundred years, we've seen massive waves of colonization primarily coming from Western Europe, but other parts of the world as well, and then colonizing indigenous peoples. And what's remarkable is we see a lot of similar health disparities and health challenges for indigenous peoples after colonization. So there really is an impact on health from colonization. But I also like to acknowledge that we have so much similarity across the indigenous peoples. You can look up, across North America with my group in the Northern Plains as Lakotas, and the Sami groups here in Northern Norway, indigenous peoples, and Nenets tribal groups. And I've been looking into this a lot in recent years and trying to identify some of those similarities across indigenous cultures. And just very briefly, it really is fascinating when we look at my people as the Lakota. You can see historically we lived in teepees, in communities, we had domesticated animals, and this image is from about 100 years ago. At around the same time, about 100 years ago, in Norway, the Sami people were living in a very similar fashion. In communities, the dwellings were teepees, they had domesticated animals, and actually not too far from them in Northern Asia, in current times, the Nenets tribal groups in Siberia are living in teepees, and they have domesticated animals, and very similar lifestyles across indigenous cultures, even though we're looking at 3 separate continents in the world. So a lot of my work in recent years has been examining indigenous populations, but also the health challenges that indigenous peoples face. And there is a common history of colonization. And what's interesting is that the more colonization that's occurred, the worse the health status is and the more marginalized indigenous peoples can be. So looking here at the North America, we have a lot of cultural groups, and it's important to recognize that indigenous peoples are not one homogeneous group. There's a lot of diversity across indigenous cultures, indigenous peoples, and history. But we do have some commonality that expresses itself in health disparities. So if we kind of move forward in time and look at the map of the United States, there are now only 7 states in the US that have at least 3% American Indian or Alaska Native population. So that includes Alaska, Montana, North Dakota, South Dakota, Arizona, New Mexico, and Oklahoma. And for those from Alaska, I apologize. I know Alaska is not off the coast of California, but this is the best map that we have to look at these numbers. So when we look at this, we recognize that the vast majority of indigenous peoples of the US live in the western part of the nation. Well, why is that? Why is it that there are so few indigenous people left in the eastern part of the nation, including in Massachusetts, where Harvard is located? Well, what we have to be cognizant of is the impact of colonization. And colonization started in the East. So as a result, the indigenous populations in the eastern part of what is now the United States really absorbed the brunt of colonization. And even the original 13 colonies are literally the colonies from Europe. And colonization led to all kinds of challenges in terms of spread of disease and warfare and loss of entire cultural groups due to colonization. This is not unique to the United States. We see similar patterns of marginalization and health disparities for indigenous peoples in Canada, indigenous peoples in Australia, in the Pacific Islands, et cetera. So it's really fascinating. We now have internationally these groups of English-speaking indigenous peoples. So in English-speaking indigenous peoples like myself, I speak English and I live in the US, but I am indigenous. We also have a lot of English-speaking indigenous peoples in Canada, Australia, New Zealand, Hawaii. And what's fascinating is we see a real similar pattern of health disparities across the indigenous peoples who were colonized by Britain. So the British colonies have kind of led to a similar pattern of health challenges across multiple populations. So let's look at the US in particular. And I think it's important to have a better understanding of historical context to really have an understanding of the health challenges that we face today. But even more important, what are the potential solutions to resolving these health inequities? Well, at the time of contact, at least for Columbus, the entire area was indigenous land and indigenous territory. So it's estimated that there may have been around 20 million indigenous peoples in North America at the time of contact, probably around 5 million or so who were in what is now the United States. So the entire region was indigenous, and obviously the 13 colonies were just devastating to many of the northeastern tribes. So I'm sure for many of you who are in Massachusetts, you're aware of Amherst, Massachusetts, and Amherst College. He's actually very well known in Indian country because he is the colonial political leader who ordered the distribution of blankets from a smallpox hospital to the regional tribes with the purpose of killing them. So this is really a terrible part of our history and obviously very traumatic. So the first documented case, quite honestly, of bioterrorism is our own colonial government. Now, it's not framed that way in most history books, and most schools don't teach this part of our history, but it is a real part of our history. And I talk about these things not to make anyone feel bad. That's not the purpose. But we need to understand the truth of where we come from, the truth of our history, and the truth of the basis for health inequities if we're ever going to approach equity. So in order to achieve equity, we have to walk through truth, even when it's unpleasant, even when it's items that we might not want to think about or talk about. But this is actually documented in terms of what happened with Lord Jeffrey Amherst. You can Google Amherst and smallpox, and you can actually find this. These are posted in various websites. But this is a letter from Jeffrey Amherst to one of the colonial army leaders. And I know it's difficult to read the cursive, but here's what he said. And this is from Jeffrey Amherst. He said, "You will do well to try to inoculate the Indians by means of blankets, as well as to try every other method that can serve to extirpate or get rid of this exorable or horrible race. Extirpate this exorable race. I should be very glad your scheme for hunting them down by dogs could take effect." So this is fascinating. This is a part of our history as Americans, part of our US history. But again, not very well described in most history books. I think because it paints Jeffrey Amherst in a negative light, but in a truthful light. These are his words. So what do we do now? We honor him, right? There's a city named after him in Massachusetts. There's colleges named after him. So it's really fascinating when we look at these issues and recognizing that when we read history and when we study history, it literally is his story, is history. And who's writing that history? It's not the colonized, it's the colonizers. And I think if we're ever going to get to equity, we need to understand this truth so we can start establishing solutions as we move forward. Well, moving forward in history, we know that many of the tribes in the Southeast are no longer in their homelands. And in 1830, there was a law called the Indian Removal Act, and more commonly known as the Trail of Tears. But the Indian Removal Act, the goal was to remove tribal members from southeastern United States to what is now Oklahoma. So in that process, many tribes were removed from their homelands and then placed into Oklahoma. What's fascinating, of the 38 or so federally recognized tribes in Oklahoma, only 4 are actually from Oklahoma. The rest were relocated from other parts of the nation. And an interesting thing occurred. In many of the tribes, tribal members, some of them agreed to be removed and others refused, and they stayed put in their homelands. So that's why we have this interesting dynamic now in which we have Seminoles in Florida, Seminoles in Oklahoma, Cherokees in North Carolina, Cherokees in Oklahoma, Choctaws in Mississippi, Choctaws in Oklahoma. You kind of get the picture. And the reason we have that division of population is because of the Indian Removal Act of 1830. And that's when these processes occurred. So loss of homeland, loss of territory, loss of culture, loss of language, loss of traditional leaders, loss of traditional food systems, and then greater dependence on federal programs, even for simple things like food. So we saw huge changes to the cultures of indigenous Americans in the Southeast, really dramatic changes as a result of the removal or the Trail of Tears. Also, the discovery of gold was very bad for the California tribes. And unfortunately, many of the tribes were wiped out during this time frame with the pursuit of gold in California. And there was actually a time when there was a bounty when you could actually kill American Indians for a bounty, really to clear the way for the gold rush. So that really decimated a lot of the California tribes. So that's why we have the pattern of population distribution that we have in the US. And there's many, many other examples. That's just a high level overview of some of the key events. But you can see those 7 states, Alaska, Montana, North Dakota, South Dakota, Arizona, New Mexico, and Oklahoma, are the states that have at least 3% American Indian or Alaska Native population. And this map is from the US Census website, looking at the population by county. And where I am from, in Pine Ridge, South Dakota, still high concentrations of American Indians here, and really throughout the Dakotas, and this is the area in which I work now. So I'd mentioned the estimated population at the time of contact in what is now the US. It's estimated it's probably a little over 5 million people. There's no way to know for sure. Of course, we didn't have a census back in the 1400s, but that's our best estimate. What's just absolutely fascinating is that by 1900, the numbers of American Indians had dipped down to about 200,000. So from over 5 million to 200,000. It was almost a complete genocide of indigenous peoples of the United States. The good news is, in the 2010 census, there are 5.2 million people self-identified as American Indian or Alaska Native, either alone or in combination with other groups. So our population numbers seem to have rebounded, but what is the impact, the long-term impact on health when we have this type of loss and really near genocide of an entire race of people, the indigenous Americans? Well, we're going through terrible challenges with the pandemic right now as well. I think it's also important to recognize that the history of Indian health is just riddled with pandemics and epidemics that we've had to deal with. Here in North Dakota in the 1830s, there was a smallpox epidemic that really destroyed several tribes, including the Mandan, the Hidatsa, and the Arikara nations of peoples. And it's estimated that there were about 10,000 tribal members from those 3 groups in North Dakota, and only about 130 people survived out of over 10,000. So these are separate tribes from a cultural perspective, but because their numbers were so small based on the smallpox epidemic, that they brought those 3 tribes together to form what's called the 3 affiliated tribes, or the Mandan, Hidatsa, and Arikara Nation. So it's fascinating. The 3 affiliated tribes are 1 federally recognized tribe, but they are 3 tribes culturally. And the basis for that really is an epidemic of smallpox. So our history has also dealt with all kinds of epidemics and worldwide pandemics, including things like smallpox. So kind of looking at this from a federal policies and federal law perspective, how is it that the federal government dealt with these health challenges and even dealing with trying to access more territory in what was becoming the United States of America? Well, in 1849, military control of Indian affairs ended and the BIA was transferred to the Department of the Interior. So the Department of the Interior is the department that houses the Bureau of Indian Affairs. And what's fascinating that the BIA has now been around for 170 years. And it took until this year for the first American Indian to be nominated to be Secretary of the Interior. That's Deb Haaland from New Mexico. She's a member of one of the Pueblo tribes in New Mexico. So she's right now awaiting Senate confirmation to be Secretary of the Interior, first Indigenous person in what is now the 172-year history of the Department of the Interior. It's really remarkable. In terms of trying to address some of the health issues, in 1911, Congress made the first federal appropriation for health services for American Indians and Alaska Natives, but not on a recurring basis. It was one-time funding really to address epidemics like smallpox as well as tuberculosis. And it really wasn't until the 1920s when we started seeing recurring funding to address the health disparities that were created by this history of colonization. So I spent a lot of time and a lot of my research in recent years trying to understand the intergenerational basis for chronic disease disparities among American Indians and Alaska Natives. And a lot of people are uncomfortable with the term genocide, but it's exactly what happened, unfortunately, here in the United States. And again, not to try to make anyone feel bad, that is not the purpose. It's just that we need to understand the truth if we're going to find real solutions as we move forward. So there's a building arena of historical trauma, and Dr. Gahn has really led a lot of this work in trying to understand the impact of historical trauma on subsequent generations. And another component of our history that has had a severe traumatic impact on many Indigenous peoples is the forced boarding school experiences. So for American Indians, boarding schools were not luxurious places to attend. These were forced removal from homes. And the way that they were able to force the removal is that after tribes were put on reservations and they lost access to traditional food systems, they became dependent on the federal government for food programs. And they were called rations. And essentially what the families were told is that if you do not give up your children to go to boarding school, we will cut off your rations. You won't get any food. So the option was give up your children or starve, is essentially the policy put forth. And there's all kinds of stories of abuse and neglect that occurred in the Indian boarding schools, but even just abandonment and forced removal and all of the negative things that could occur. Stories of children being physically beaten if they spoke their traditional language, so forcing English on the children. So huge challenges when we think about the boarding school experiences. This is a picture from the Carlisle Indian School in Carlisle, Pennsylvania. And this is the graveyard. And next to the boarding schools throughout the country, there's these huge graveyards of American Indian children who died while they were at boarding school. And I visited here a couple years ago. There was a boarding school healing conference where I presented and where we met with other Indigenous peoples from around the country. And it's just haunting. And there's a sense of heaviness to visit the graveyard. Each one of those headstones represents an American Indian child, usually between age 6 and 12. And we don't know why there was so much excess death at the boarding schools. We know that there were outbreaks of things like tuberculosis, but it doesn't answer as to why there was so much excess death at these boarding schools. And one of the questions I have is, what about the survivors? What is the long-term traumatic impact if you, as a child, are watching your friends and playmates die at such an unnaturally high rate? That's got to have a long-term impact. And when I look at this image from Carlisle and look at all these beautiful Indigenous babies, these children, and I think about how vulnerable they were in these types of settings without family to protect them. And I wonder how many of these kids might have had, autism or maybe learning and language challenges or disabilities, and how vulnerable they were to abuse. And again, not to make anyone feel bad, that's not the purpose, but we need to understand this truth, and we need to understand the impact of this type of practice on entire populations of people. And of course, here we're talking about Indigenous peoples of the Americas. It's a very famous picture of a Navajo young man on the left. That's when he entered Carlisle, and then 3 years later, how he had been changed. And this was considered a success story of boarding schools, that they got rid of the Indian culture from the young man. And the motto of the Carlisle Indian School was, "Kill the Indian, save the man." Kill the Indian, save the man. So what are the kids taught is that their culture was bad, their language was bad, that what they were brought up with was wrong. So what happens when they go home? What is the sense of belongingness? What is the impact on self-esteem? What's the impact on health-related behaviors? And what have they learned about parenting in this process? This is another famous picture looking at some young men from Pine Ridge, where I am from. and looking at when they entered the school in 1883 on the left, and then 3 years later. And again, this is kind of advertised as a success story for boarding schools. And these are very unpleasant things to think about and talk about. But again, we have to understand these things in order to understand why we have these terrible disparities, but even more importantly, what can we do to fix it? So I think that the field of epigenetics is really fascinating. And for those who don't know, in epigenetics, we look at the changes to DNA from things like toxic stress. And it's been well documented that toxic stress can actually change gene expression. You can have things like methylation of the nucleotide sequences in DNA. It can have an impact on telomere length where the chromosomes divide, impact on histones, so all of the biology associated with DNA, it can be impacted by toxic stress. And there's some really good studies in animal models that show when you have entire populations that are under toxic stress, those DNA changes can be passed on to subsequent generations. We may or may not find linkages between toxic stress and epigenetics to historical trauma, but that's an area of research that's growing. And I think epigenetics can provide us a scientific platform to better understand the intergenerational impact of these toxic, stressful events. So as we kind of go through that timeline and looking even at some of the food programs, so WIC, Women, Infants, and Children, and FDPIR is the food distribution program on Indian reservations. And those are both USDA-sponsored food programs. So when I was working as a full-time clinician in Arizona back in the 1990s, on the reservation where I worked, the WIC program, again, Women, Infants, and Children, the WIC program is basically a baby formula distribution center, just handing out baby formula. And what's fascinating is that we know, it's been proven, that the population of children who grew up on formula have higher rates of diabetes than the population of children who had breast milk. And fascinating when we look at WIC, that the unintended outcome of WIC is that we had higher percentages of formula feeding in impoverished populations. The populations that were most at risk from formula feeding of children were the ones that had the highest rates because it was free as part of the USDA programs. And just even think about the word formula. Does that sound appealing to anyone? Come on over, we'll have a glass of formula. It's called formula for a reason, right? It's chemicals, essentially. So in fairness, WIC has done a much better job in recent years of advocating for breastfeeding, because that's the most healthy way for babies to get nourishment, and trying to go away from just handing out baby formula. Well, when we think about traditional food or American Indian food now, a lot of people think of fry bread, right? So what's interesting, if you look at the history of fry bread, it's not a traditional American Indian food. We never fried dough. The origins of fry bread are actually in the commodity food program, the food distribution program on Indian reservations. And people basically were just trying to do the best they can with their commodities, things like flour, lard, and vegetable shortening. So the origins of fry bread are actually in the commodity food program. I talk about this when I go home for ceremonies or for feasts, and quite often people get angry with me because they love their fry bread. But if we want to call it traditional food, it's traditional USDA food, not traditional American Indian food. And there is some compelling evidence now in nutritional epigenetics that these types of toxic foods can have an impact on DNA. So again, another area as we move forward, let's identify those challenges. Let's investigate what we're actually doing to future generations through toxic foods and toxic stress. Well, I'm sure many people are familiar with the Adverse Childhood Experiences Study, or the ACE study. And we know that the more exposure a child has to adverse experiences, the worse their health status is as an adult. And ACEs, or adverse childhood experiences, have lasting effects on health, including higher rates of obesity, diabetes, suicide, heart disease, cancer. Also on behaviors, more adverse childhood experiences, we see higher rates of smoking and alcohol intake and drug abuse. And ACEs also correlate with worsening life potential, lower graduation rates, lower academic achievement, and higher rates of poverty. So what's fascinating In the original ACE study, they identified 10 types of adverse childhood experiences. And there's a dose response effect. The more adverse childhood experiences someone has, the worse their health status is as an adult. And when we think about this, it makes a lot of sense. Where if we have adverse childhood experiences, that's going to disrupt neurological development, that'll have an impact on social development and emotional and cognitive functioning, have an impact on behavior, subsequent disease and disability, and early death. And one of the things that I've been very pleased to see with the CDC through their National Center on Injury Prevention is recognizing that it's not just adverse childhood experiences at the base. There are social conditions and local contexts in communities that lead to higher risk for adverse childhood experiences. And CDC is now even talking about generational embodiment and historical trauma as risk factors for communities to have higher rates of adverse childhood experiences. So these are important things to keep in mind, is that not every community has the same risk for adversity in childhood. And this is an area where we can intervene and we should intervene to try to improve outcomes. Does adversity stop at age 18? Well, unfortunately, no. We still see a lot of adversity in adulthood and toxic stress. And some of the outcomes of that are more addiction, higher rates of mental health challenges and suicidality, and higher rates of poverty. And living in poverty is stressful. Living within communities where they suffer from racism is stressful. And when we think about some of the generations of boarding school experiences and that loss of traditional parenting, we can see how this passes from one generation to the next in the form of adverse childhood experiences. What I was taught is that historically, it was the role of one generation to raise the next generation. So from a traditional perspective, I have just as much responsibility for my nephew as I do for my son. And what a beautiful way to think of raising children, is that the entire generation is responsible for that entire next generation. And the idea of a nuclear family really is a colonized perspective. So what we need to do is indigenize and decolonize even how we consider families in our communities, and how we can create more safety nets to improve outcomes for children. So we have significant challenges, obviously. A lot of social determinants or influences on health outcomes. We have higher rates of poverty, unresolved trauma, even political challenges that we face. You know, if you look at those states where we have high concentrations of American Indians and Alaska Natives, they're not necessarily the most progressive states politically, and they're not always good with tribal relations at the state level. But also our issues are largely neglected. I think when I give these types of talks, it's remarkable how many people are not aware of the history, the truth of history. And we still suffer from racism. I wish that we were a post-racial society. We are not. I mean, if we look at all the even current challenges that we're facing today. So the outcomes of these social determinants, of course, are health disparities, and then inequities in education and poverty, ongoing racism, and challenges related to health outcomes and early death. So we have to address equity in a much more comprehensive manner. You know, a medical perspective, a behavioral health perspective, a public health perspective, but also an economic perspective, a sociological perspective. And we have to look at this more comprehensively and recognize that all of these inputs in modern society, all of them have an impact on health outcomes. So we have to broaden our perspective. I really like this image. It kind of shows the difference between equality and equity. And on the left, we can think of equality as kind of the one size fits all approach to programming. So you can think of the boxes that they're standing on. That could be a curriculum, right? That could be the history curriculum, for example, in the elementary school. It could be a medical curriculum, or it could be a health plan. It could be the Medicaid plan for your state. And we take the one size fits all approach. But what we can see is that the guy on the left didn't need it. It's serving the one in the middle pretty well. And the guy on the right is still underserved. So from that perspective, we're looking at the package of services rather than the outcomes. And I think we need to be more outcomes focused. And within equity, we recognize that there's a social justice imperative and that we want to raise everyone up to the optimal health that each individual can achieve. And it's not just about the package of services, but what that means is that we have to be more creative. We have to be more thoughtful in developing medical plans, more thoughtful in developing curricula, and recognizing that the one-size-fits-all approach has not worked for American Indians and Alaska Natives. We have to be smarter about this. So I've been showing this slide for a number of years, and a couple of years ago, someone sent me an image that I thought was just brilliant. And the question is, why is that fence there in the first place? You know, is it just about the package of services to overcome the barrier, or do we need to get rid of the systemic barrier? And one thing I appreciate about this idea is that perhaps we need to think of the systemic barriers as things like underfunding of Indian health service generally, but also even the curricula, you know, even the workforce. We don't have enough Indigenous peoples leading agencies. We don't have enough Indigenous peoples as deans of medical schools. Right now, if you look at the number of American Indians who are the dean of a medical school, it's 0. There are 0 American Indian medical school deans. There are only 2 of us who are associate deans. So I'm 50% of the American Indian associate deans at medical schools. That's not a pat on the back, that's an indictment on the field. And I think that part of what we need to do is leadership development and recognize that if we're going to break down those systemic barriers, we need equity and representation at the highest levels of education and health. Another systemic barrier is just the fact that the US has never lived up to its treaty responsibilities to provide services to American Indians and Alaska Natives. And going all the way back to the Constitution, it states very clearly that Congress shall regulate commerce with the foreign nations and the Indian tribes. So even way back in the Constitution, tribal nations were put on par with foreign nations and recognizing tribal sovereignty. But we also have treaties, and treaties are the highest order of law in the land. And on the right here, this is one example of a treaty of hundreds of treaties. This is with the Potawatomi Nation, 1846. I know it's in fine print, but it says that the tribes will give assurance of fidelity and friendship to the government and the people of the United States, and the United States giving at the same time promise of all proper care and protection. Promise of all proper care and protection. Have American Indians received all proper care and protection? Well, no, not even close. If we look at our systems like Indian Health Service and Bureau of Indian Affairs, the federal government is in breach of contract if we look at the treaty as a contract. And we need to have equitable outcomes under law, and we're not getting them. So quite often the US government is the first to point fingers at other nations for human rights violations or treaty violations. We need to look at what we are doing, and that's got to be part of the solution as well. I never went into medical school thinking I'd learn about law and treaties, but that's the upstream root cause of many of our challenges, is that the federal government has benefited tremendously by allocating our resources, and they have not lived up to their responsibility to provide services like housing, education, and healthcare. So again, one of the big challenges in terms of a systemic challenge is just not having enough resources for Indian Health Service. This shows various federally funded health programs, including Medicare, funded at over $13,000 per person per year. The VA funded over $10,000 per qualifying veteran per year, Medicaid over $8,000 per person per year. Even for federal employees, with federal employees' health benefits over $7,500 per year, and IHS $4,000 per person per year within the Indian Health Service. So is that promise of all proper care and protection? It's right in front of us. We have these inequities that are not just historic. This is today. This is the type of inequity that's leading to additional health disparities because we don't have the resources needed to address our health challenges. So coming to up to this year, at least this past year, and the year 2020, I find it ironic that 2020 vision is supposed to be perfect vision, right? But the year 2020 obviously was horrible. The COVID-19 pandemic, the subsequent economic recession. We also saw a lot of racial division and violence, and the Black Lives movement and counteracted by white supremacist movements and a lot of political unrest. We lost some major social justice icons in the year 2020. Supreme Court became more conservative and I'd say less friendly to American Indians and the federal Indian law. We had an assault on the nation's capital. Of course, that was just in 2021, but a lot of toxic stress. And I worry about, what's going to be the impact on young people who are observing all of this and in many ways experiencing all of this. One of our big challenges that we haven't resolved is racism, and that's an ongoing challenge. And there's been a lot of research in recent years looking at the trauma of racism. And this is from a article published by Williams and others. It says many ethnic and racial groups experience higher rates of post-traumatic stress disorder as compared with white Americans. One explanation for this experience is the experience of racism, which can itself be traumatic. And then even looking at the American Academy of Pediatrics in 2019, they had a policy statement, and they state that racism is a social determinant of health that has a profound impact on the health status of children, adolescents, emerging adults, and their families. Although progress has been made toward racial equality and equity, the evidence to support the continued negative impact of racism on health and well-being through implicit and explicit biases, institutional structures, and interpersonal relationships is clear. So I'm so pleased to see that there's research in this area and that the national organizations are at least acknowledging that it exists. And that's a first step toward trying to promote equity. And then trying to understand the link between racial trauma and substance use among American Indians and Alaska Natives. Oppression is the overarching umbrella for all sickness with drugs and alcohol. Participants also identified historical trauma resulting from colonization as a manifestation of race-based stress that drives behavioral health problems. And this is from an article published in American Psychology just in 2019. So this field is growing, and we're identifying that the history of traumatic experiences is still continuing as we march forward through time. Another trauma, of course, is COVID-19. And the tribal nations have been hit much harder than most communities by the pandemic. And when we think about a way to respond to a pandemic, we need good public health infrastructure. And we also have to provide what they identify as the 3 T's: testing, contact tracing, and treatment. And for the tribes, unfortunately, we've had limited infrastructure. And in many cases, the testing, tracing, and treatment has been inadequate. And I'd say the 4th T in our communities is trust. The messenger really matters when we're looking at the response to things like a pandemic. And we have to have trusted individuals and trusted places in order to have a better response. And without that, we can see the challenges related to poor health outcomes. And we see that right now. And unfortunately, a lot of our communities are losing elders that are knowledge keepers, cultural leaders, traditional language speakers. And there's real concern with indigenous populations of the long-term impact of what's happened with the pandemic. So in thinking of just basic public health infrastructure, we don't have the workforce, information data systems, and organizational systems that we need to mount a meaningful public health response. So we need to do something about that. So what are we doing here at UND? Well, we've had the Indians into Medicine program, or INMED program, since 1973, and it's focused on increasing the numbers of American Indian physicians. We're now at about 250 physicians who graduated from INMED programming over that time frame. And our second-year medical students are the class of 2023. So they are actually the 50-year anniversary class of INMED. And we're planning some meaningful events in the next couple of years to acknowledge 50 years of INMED. In 2019, we started the Indigenous Health specialization in our Master Public Health program. And just this last year, very pleased, as Dr. Gahn had mentioned, we started the Indigenous Health PhD, the first of its kind in the nation, just last year. And we have 19 students in the first cohort of the PhD. 17 of the 19 are Indigenous peoples. And it's important to acknowledge we have non-Indigenous peoples who are champions and advocates for what we're doing. And we welcome all races and ethnicities to join us with this type of work. We're also establishing the Indigenous Trauma and Resilience Research Center, recognizing that there's a trauma that's occurred throughout time, but we also have a tremendous amount of resilience and strength as Indigenous peoples. We're still here in spite of all of the traumatic experiences. So we have to have a better understanding of measures of stress and measures of resilience, how our adverse childhood experience is impacting us, but how our cultural practices serving as protective measures. How do we measure that? And then the impact of traditional foods on nutritional epigenetics. There's some really compelling initial evidence that we can actually demethylate DNA. We can reverse epigenetics with healthy, whole, traditional foods. So that's the direction we're moving in terms of research. Our curriculum is a lot of methods, in terms of quantitative, qualitative methods, but also Indigenous research methods. As Indigenous peoples, we've been doing research for millennia. We just had different terminology for it. Also, we've been evaluating programs. So we have Indigenous evaluation frameworks as part of the curriculum. And then Indigenous leadership and ethics, that we have a wonderful history of servant leadership and transformational leadership. And the ethical framework from Indigenous populations, I think, is a wonderful framework for leadership in spite of whether or not someone is Indigenous or not. So that's part of our curriculum. Just want to show this picture in the middle. There's Dr. Gahn as a guest lecturer in one of our classes to our Indigenous Health PhD, and it is available through distance. So we have students all over the US and Canada who participate in our PhD program. Very proud of our faculty. We have 5 Indigenous health scholars working full-time in this space. In addition to myself, there's Dr. Siobhan Westcott. She has her MD from Harvard and MPH from UCLA. She's Athabascan from Alaska. Dr. Melanie Nadu is Ojibwe from North Dakota. She has her PhD and MPH in epidemiology from the University of Minnesota. Dr. Nicole Redvers is Dene First Nations from Northern Territories in Canada. She's a naturopathic physician, has her MPH from Dartmouth. And Ursula Running Bear is Shichangu Lakota. She has her PhD in clinical sciences and is a research methodologist working with us. Huge challenges, and no individual can do this alone. No university can do this alone. This is going to require a group effort. And sometimes it feels like we're pushing the boulder uphill, but this is what we need to do. And for those of us who are fortunate enough to be in positions of academics and having had the opportunity to get formal education, it's our responsibility to keep working even when it's very challenging. And I love this quote: "Struggle is necessary for a time. There is also a time to build, flourish, and prosper, to thrive. This is what culture empowers. You don't need to constantly struggle to justify or validate your life. Your ancestors' prayers already took care of that." And I look at all of our students now. This last year, we had, like I'd mentioned, 17 Indigenous PhD students who are Indigenous people. We had 8 INMED first-year medical students. So at UND alone, that's 25 American Indian first-year doctoral students at our little University of North Dakota. It can be done, but each one of those students is an answered prayer. We've had generations and generations of challenges and suffering, but those prayers are being answered today, and we all need to be a part of the solution as we move forward. I also love this image from the Black Legging Society of warriors. And what they would do is say, this is where I'm going to make my stand, and put the lance into the legging so that they can't run away. And this is where we make our stand. This is where those of us who have the strength to make a stand and to have the courage to fight for our people, that's what we need to do. And there's so much beautiful history and so many beautiful lessons to be learned from this type of courage and this type of humility to ensure that the next generation of our people can have a better outcome. And finally, we learn a lot from the natural world and from the animal nations, or the Teoyate, we call it in Lakota, the buffalo nation. And just observations when we see a herd of buffalo out here, and particularly this time of year when the winters can be so harsh, it's the strongest bulls that stand facing the wind so they can protect all of those who are behind them. And I would put forth that for any of us who are strong enough to face the wind, it's our responsibility to do that. And it's our responsibility to ensure that we're protecting those who might be vulnerable. That for those of us who are fortunate enough to have an impact on education and health and outcomes, that we do everything in our power to lead and to improve the lives and outcomes for our people. Thank you all very much for the time and attention. I think I'll go ahead and stop sharing here and hand it back over to Dr. Gahn for any questions, and also Dr. Harris.
Well, thanks, Don. What an impressive and descriptive overview that's so informative, so orienting to these issues. Your deep knowledge and passionate commitment really shine through, and you're just the perfect person to help kick off this inaugural instance of our Indigenous Health Seminar series that HUNAP and Global Health and Social Medicine are committed to launching together. So thank you so much. Part of your overview really impresses upon us the importance of a social medicine approach to even begin to think through the problems and prospects for addressing Indigenous health disparities. I'm so proud of my colleagues and to be in this department because of our commitment to understanding historical and social context and all of the social determinants that lead to these desperate health inequities that are the product of colonization and oppression and all of the sorts of things that you've helped to draw important attention to. So thank you again so much for these comments. Before I ask you a question, let me just first remind everyone, please use the Q&A function to type your comment or question so that in the time remaining, we can get that to Dr. Warne for a response. And Scott, thanks again for being willing to help forward those to us as they arise. You know, I have a question for you, Don, in terms of the prospects for addressing these health inequities. You've offered a lot of advice and wisdom already. One initiative that we have happening in our own department in global health and social medicine is an actual Lancet commission dedicated to reparations and redistributive justice. And there's a whole team of people, but it's really led by my colleagues, Jean Richardson and Paul Farmer. We're going to have a special article published in the Lancet when it's all said and done about lots of populations around the world for whom we can see reparations being an important opportunity to reverse this legacy of health disparities. But I'm wondering if you have some ideas about the way that we might, as a nation, make some repair for the colonial legacy and for the incredible health burdens that this has placed on Indigenous peoples here in the United States.
Yeah, in other nations, there have been truth and reconciliation commissions for the Indigenous populations. In Canada, they've done a very good job with this. Even in Alaska, in Australia, they've also had some meaningful work in addressing truth and reconciliation. I think there's some good models at the national level to consider. But I think also in a very practical way, we need to have a reassessment of the history that we teach our kids. I mean, my own children go to public school and they get taught things that are just simply not true. And if we have an entire, multiple generations of people who are taught things that are not true about Indigenous people and about our own history, of course we're going to see misunderstandings. Of course we're going to see people making judgments and assessments that are based in fallacies. So I would really like to see truth and reconciliation at the federal level, but let's also re-examine how we teach history and whose history is it that we are teaching that could help future generations.
Thanks for that. I sometimes point out in my undergraduate seminars the way in which stereotyping and misinformation proliferates in society about Indian people, in some ways somewhat distinctively these days. I use the Disney film Peter Pan, which all kinds of kids watch today. You can go to Best Buy and buy it, and it has the most racist depiction of Indian people you can imagine. And Disney has long edited other instances of these kinds of stereotypical misrepresentations, but not this one. So thank you for that. I'll ask one other question before we open it up, Scott. We recently had a commentary in the Boston Globe published by one of our medical school students here at HMS. Victor Lopez Carmen, who's Dakota and Yaqui, wrote this fantastic personal comment all about his own entry into medical school and the fact that so few Indigenous and Native people end up in medical school. He's actually a descendant of Charles Eastman, who was important in your neck of the woods there in South Dakota for a time. It's all about, of course, widening the pipeline. So you already talked about how University of North Dakota has this INMED program that's about to celebrate its 50th anniversary, graduated some 250 Indian physicians. I wonder if you can say a little more about what are the ingredients, the secret sauce that's necessary to really pull Native Indigenous people into medical school and to get them through and credentialed and ready for serving our communities or doing research or all the things we need done to address this cataclysm of health inequities.
Yeah, and that's one of our big challenges is how do we actually do this? And through INMED, our programming actually starts with our summer institute, which includes middle school and high school students who spend 6 weeks with us on campus. So we like to say our program is middle school through medical school. You know, we're starting very young, because if a medical school was interested in increasing the numbers of medical students, you can't just look at the college graduates with high MCAT scores. You have to start much further upstream. So that's why we do that. And we're very pleased that many of our summer institute students go on to other universities and medical schools. That's wonderful. That the longer term impact is more important than which particular university they attend. But the other thing that we've seen that is very effective is to have more Indigenous faculty and Indigenous faculty in leadership positions. And I think when I was going through medical school, we kind of knew as pre-meds, for lack of a better term, what the Indian-friendly medical schools were and which ones simply were not. You know, you just kind of know that through word of mouth. It's a small arena when you look at those of us who are college graduates. So, so if a medical school was interested in doing this, you have to start earlier and for working further upstream to create those relationships. But then also having Indigenous people in faculty and leadership positions is vitally important.
Thanks, makes very good sense. Scott, I wonder if we have a question you want to forward for Dawn to consider.
Sure. So Dr. Warne, first of all, thank you so much. We only have 79 questions now that have come through. So thank you to our audience members for being so engaged and participating. And certainly for the ones that Dr. Warne can't get to during the next 20 or so minutes, you'll certainly get a copy of all those. Some of these may be related. So, and by the way, many of these comments also express their gratitude to you. Sarah Deere asks, can you discuss mental health / psychiatry access? My understanding is that on some reservations, there's only mental health available for psychiatric emergencies. How can we make mental health more available on reservations? And then there's another question which may or may not be related, but saying, are traditional Indigenous medicine and ceremonies recognized as a source of treatment within public health? So I'll throw those two out first.
Yeah, excellent questions. And for most of our reservation communities, we do not have local access to psychiatry. There might be some addiction counseling, there might be some programming available, but generally speaking, we don't have psychiatrists on our reservations. Some of the larger reservations with hospitals can have staff psychiatrists, but generally that's not as readily available. And then we also run into other policy-based challenges. So for example, in South Dakota, where I am from originally, there is a network of community mental health centers, which focus on primarily addressing mental health for the Medicaid population. And of course, we have high rates of poverty in addition to high rates of need for mental health services. Guess how many of the community mental health centers are located on a reservation? 0. That is a policy and structural barrier that is put in place purposefully. They could choose to put a community mental health center on a reservation if they wanted to, but they just don't do it. So I think we also have to recognize there are structural barriers. It's not just about being able to hire someone, it's how do we integrate with limited resources, better access to these services. And I really believe that telemedicine has a lot of potential to help us in these arenas. We just haven't had the infrastructure even for telemedicine the way that we need to. And I've been pleasantly surprised, and maybe Dr. Gahn has seen this too, but a lot of our community members seem to respond just fine to telemedicine, telepsychiatry. I didn't know if that would be the case or not, but it's certainly better than having no access whatsoever. And then in terms of the traditional approaches, yes, and we don't look at things just in terms of physical health and the physical body, but recognizing that health is a balance among physical, spiritual, mental, and emotional forces. And that to be healthy, we must be in balance in all those 4 directions, but also recognizing that promoting health and wellness and well-being is public health. And traditional medicine is rooted in those public health principles of wellness and balance.
Thanks, Don. I wonder, I remember that presentation I saw way back that I mentioned in the introduction at Dartmouth, where you were talking about the medicine wheel and the 4 quadrants and the way you just described it. I wonder if you're comfortable saying anything about indigenous traditional means or working with indigenous folks who have been traumatized or are coping with serious disabling distress.
Yeah, what I've observed, and again, we don't have large scale studies. These are very sensitive things that are difficult to study and get formal data. But what I've observed is that some of the most successful programs focusing on recovery incorporate traditional practices. And in Phoenix, there's a Phoenix Indian Rehab, used to be called that, now it's Native American Connections. And they have a very comprehensive approach to recovery and wellness following challenges with addiction. But traditional approaches are at the core of it, whether it's ceremonies like sweat lodge or talking circles, incorporating traditional healers, traditional language, vision quest, all of these things that are really vital from an indigenous perspective. One of the challenges, of course, as I had mentioned, we don't have these things available on a typical Medicaid plan, right? So one size fits all. So, and these types of programs and these policy-based services, we can say that, well, if we offer this service to one population, we have to offer it to everyone. If we cannot offer it to everyone, we'll offer it to no one. And that's equality, right? But it's not equity. And it's not intelligent that we have methods to improve outcomes and we have methods to embrace people and promote equity, but we build structural barriers to implementing those things. So it's a huge arena, and I see tremendous value in integrating traditional and modern medicine, but there's a lot of complexity in doing that.
Indeed. Scott, any other questions there?
Yes, they're now over 100 altogether.
Okay.
We're going to be here for a long time. So Byron Good, your colleague of Dr. Gonzenlein, asks, would you talk about diversity in health conditions across indigenous groups and sources of difference across groups?
Yeah, so it's really fascinating if you look at various populations. So again, thinking about some of the indigenous populations that were colonized by Britain, so that a lot of the English-speaking indigenous peoples, we see kind of the same pattern of things like diabetes in many of these populations. And one arena where this became very stark to me is that I was asked to present at the International Diabetes Federation Conference in Melbourne, Australia. And this is probably in 2000 or 2001, it was a long time ago. And I was on a panel with an Aboriginal Australian physician and a Maori public health professional from New Zealand. And we hadn't met before, we didn't share slides ahead of time, but we basically give the exact same presentation, but just insert American Indian versus Australian versus Maori. So it was the same pattern. And that's really where I started thinking more about, well, what is the commonality of the impact of colonization? So that's one of the things that we see. But of course, in other populations, the Aleutians were colonized by Russia, and there was a lot of warfare associated with that. And of course, throughout Africa and other nations, there's been other patterns of colonization where we might not see outcomes like diabetes, but we still see outcomes like inequities and early death. So it's a whole arena that needs to be further explored. But what I'm finding is that your colonizer matters in terms of the pattern of health disparities.
Great, Scott.
So again, shifting gears, this is getting back to academia. And what experience can help future indigenous faculty prepare for leadership within academia?
Well, I think academia needs to meet us partway. That I think that the challenges, again, one size fits all, right? That we have the same timeline for everyone for promotion and tenure, the same requirements. So, you need to publish in a journal with impact factor greater than 2, well, we have a very small population, and should we be punished because there are less people interested in indigenous health and they might be someone interested in genetics? And then also the time that it takes to conduct meaningful community engaged research is a much longer timeline than if you're just simply working in a lab. I mean, I have colleagues who work in a lab who can crank out, 5 or 6 papers a year without a challenge, but they don't have to engage the gels or the auger, you know what I mean? That they don't have a say. So So we can't take the one size fits all approach to promotion and tenure. And that's a whole arena that we're working on, is to try to establish what are some of the unique considerations for indigenous health scholars that don't fit well within the academic paradigm as it's currently constructed. We need to decolonize that and indigenize it and be smarter about it. But we're not going to do that effectively until we get more American Indians into dean level roles and department chair level roles. And I wouldn't say that's the fault of the current system, but I would say that without that lived experience, our current leadership doesn't know what it doesn't know. And they just have no idea what these challenges really mean. So I would say keep, as an upcoming Indigenous academic, try not to get discouraged, but also recognize that we need to work collaboratively to also have an impact on academia itself. And academics needs to become more intelligent about how it approaches Indigenous issues.
Thank you. Connor Bridges asks, you mentioned that trust as the fourth T. How do we, I guess who the we is part of the question, how do we go about building trust among Indigenous communities following so many historical and modern day atrocities?
That's a great question. And I've seen non-Indigenous people who build tremendous amounts of trust and are accepted into the communities in which they are working. I would say that the time to build trust is not during a pandemic, but long before that. You know, that the trust building and the community engagement should be occurring ongoing, and not just when we have an emergency that we need to address. So what I would say is that for building trust, it takes time and genuine commitment. And we have to go to the communities and meet the people where they are. And I've seen over the years, again, non-Indigenous medical providers or faculty members build really strong relationships and be trusted partners, so it can be done. And I've seen Indigenous academics who don't do a very good job of engaging people as well. So it's not just based on individual background. So I'd say that it takes time, and it's something that should be built continuously, not just when there's a crisis.
This is, again, shifting gears. Dr. Myrna Ramos-Diaz asks about the positive and negative aspects regarding the use of telemedicine for Indigenous peoples. And there were several questions I asked about telemedicine.
Yeah, I think that for some circumstances like telepsychiatry, in some communities, it's been well received. One of the other challenges that we have, though, is just less access to some of these telecommunications infrastructure. So if we have the type of telemedicine that's going to require broadband and high resolution, like dermatology or what have you, there's actually structural limitations and barriers to having that. But you can do telepsychiatry with a Zoom connection. You don't need the high resolution types of connectivities. So I'd say there are structural barriers in terms of just having the infrastructure to have the connections. And in some circumstances, I've seen it work very effectively. I think in an ideal setting, wouldn't it be wonderful if we had a team of Indigenous providers working together collaboratively to provide telehealth services to other communities? I'd love to see that type of an effort move forward. But again, there's still also the policy challenges. You know, how do you bill Medicaid across state lines, and how do you incorporate appropriate quality controls and maintain your accreditation? I mean, there's just so many policy considerations across that arena, but it's a whole area that needs to be further explored in health services research and health policy research.
Thanks. And a number of people are asking about sort of what resources you would first point to. So one said, do you have any recommendations on readings or films that can help better educate us or our friends on some of the histories and truths you discussed today? So what would be your top 5 or whatever it may be reading or watching list?
I'd love to get Dr. Gahn's input as well. There's a wonderful book called God is Red, and talks about the kind of the history particularly from a Northern Plains perspective. And then there's actually been a lot of good work done, I would say, recently in historical trauma, including Dr. Gahn and some of our colleagues, to really try to assess the impact on health. So if you're looking for a book, I'd say that one. One of my colleagues, Dr. Redvers, I don't think I have her book handy, but she wrote a book just recently that's focused on integrating traditional healing systems and Indigenous knowledge. Her name is Nicole Redvers, and her book is I think very good at addressing that as well. But again, I think there's a lot of good literature now looking at historical trauma. Dr. Gahn, any thoughts or input on that?
Yeah, I'll just add one which we taught in our seminar last fall. I taught it with Byron Good and Michael Fisher on colonial encounters, post-colonial disorders. And we, for the research crowd, I think Linda Tuhiwai Smith's decolonizing methodologies, that's tour de force about how to think about research that's really responsive and collaborative with indigenous communities, how to reverse all the long history of misrepresentation and so on. So I can't recommend that enough.
Yeah, and the Redbridge book's called Science of the Sacred. Science of the Sacred, yeah.
Fantastic, thank you. Seth Gale asks, in your slide that you showed American Indian Alaska Native populations from 1492 to the present as a U-shaped curve. And I was wondering, is there a sense of how these population numbers or the curve would be interpreted differently if those numbers were corrected for overall change in the total population in North America over the same time? Is the North American experience of the 20th century resurgence of indigenous populations comparable to numbers on other continents?
Yeah, so the data, that's the best that we can do with the data, because again, we don't necessarily have 100% confidence in the accurateness of the data historically. But yeah, that could be looked at in terms of the growth of the overall population. And my sense of it is that the numbers would look to be even worse. At one point, American Indians were not the minority population, right? We were the majority at one point. And then as those things have changed, I'd say our percentage of the population obviously has gone down, even as our overall numbers have gone up. So that would be fascinating to look at. It's just a little bit challenging to try to extrapolate the data and incorporate it into the broader data sets, because the accuracy of the data and how it's collected has changed over time. In addition, even census data used to be black, white, and other, right? So for a long time, American Indians and Hispanic and Asian and Pacific Islander population were the other category. So it's a little bit difficult to try to put those data sets together because the way they were collected and whether or not they're as accurate as they could have been. But it would be fascinating to look at those things.
Thank you. This is a question from earlier in the session, and it gets to the question of appropriation versus honoring. And questions from Emmeline Brown was, I've noticed somewhat of a pattern that areas in the US whose settlers wiped out the indigenous tribes in their area, like Jeffrey Amherst, tend to name towns, schools, etc. after the names of tribes only, while areas who historically had more peaceful relations with indigenous tribes name more things after words in the tribal languages. Not sure if that has any backing. This is what the questioner asked, but I have picked up on it. And your thoughts on that and general questions of appropriation?
Yeah, I haven't really looked at that in particular, but it is interesting, when we look at some of the people that have towns or universities named after them or highways, I went to medical school at Stanford, and Junipero Serra had a huge impact in that part of California. But he was also famous for saying, live by the cross or die by the sword, and he was a terrorist for the indigenous peoples. And they have Junipero Serra building at Stanford and Junipero Serra Highway. A lot of those things are starting to change. So the good news is we are seeing some more awareness. The football team in Washington, D.C. changed its mascot, which is wonderful to see. So I think we're seeing some changes on that front. But in terms of whether or not there is a correlation between how things are named and the relationship historically with the tribes, I've never looked into that. That would be a fascinating sociological assessment.
Scott, I think we need to wind down. Maybe you can forward one more question for Dawn there, please.
Oh, I thought we had 3 more hours, because that's what we're going to need here.
Yes, I know.
That's why you generate a great deal of interest. I guess I'll ask, the final one is the most general one, but difficult. If you had to name one, what would be your #1 public policy goal? Hard to do so.
Wow. Yeah. And I get that question a lot. What's the one thing we could do? But the truth is there's no one thing. This is going to require a comprehensive approach. And I guess the lowest hanging fruit and the biggest bang for the buck would be, let's equitably fund Indian Health Service. That'd be one starting point, but it's much more than that. So it's an intergenerational, highly complex issue that will not have a simple solution. It's going to take generations and complex solutions to get to equity. But again, that's why we need cohorts of well-trained indigenous scholars and indigenous health leaders and indigenous health experts. We need just, dozens of cohorts to move forward and to actually make that type of an impact. So I guess the one thing that I would love to see is equitable funding in Indian Health Service, but that alone would not solve the problem. And I did get a text from someone else watching. Actually, my brother did he produced a documentary called Seventh Generation, and that's also got a wonderful history of the boarding school experiences. So Seventh Generation as well. But geez, that was a quick hour and a half, but I'll hand it back over to you guys. Thank you so much.
Well, Don, I can't imagine anyone who could have kicked off our Indigenous Health Seminar series, again, jointly offered by HUNAP and by my colleagues in Global Health and Social Medicine. So thank you very, very much for sharing your wisdom, your insight, and this overview that's so powerful, lays the foundation. We have so much now to explore with the benefit of this background orientation. So thank you very much. I want to also allow that we're going to have another one of these Indigenous health seminars that we're going to offer through our departmental seminar, just like we've done today coming up. That's at March 3rd, same time, same format. Although I did get a flood of emails saying that people couldn't access because of a limit on the number of participants. So we might have had more participants today if we didn't have a cap. So we'll look into this cap issue. We'll also make sure that this is made publicly available, and I'll reach out to people who couldn't actually make it so that we can try to get this distributed. But maybe next time we'll figure out how to allow more people to attend. But that next seminar will feature Doctors Malcolm and Alexandra King, who are eminent physician, researcher, and academic leaders in Indigenous health in Canada. They teach at the University of Saskatchewan lately, and they'll be addressing us at our next seminar. So that'll be on March 3rd at noon. Please watch your emails for announcements and circulation. And finally, let me just say thanks again to my colleagues here in Global Health and Social Medicine, to our staff for making this possible. It went so smooth and flawlessly that I'm very, very grateful for all that you've done, and for allowing us to kind of merge a little bit while we're doing the pandemic Zoom format, which we may need to figure out how to keep in play, as someone suggested in the comments, because it does allow a lot more people to access what we do here. So we want the intimacy and the gathering and the in-person stuff and dinner. It's very important in Indigenous circles to like feed people, even as maybe we can work out a way as well to do the broadcasting as well. So thank you all again for attending. I really appreciate your time and energy, Don, and I hope to see you in person soon.
Thank you, everyone. Thank you again, Dr. Gon. Thank you, Dr. Warne. Wonderful talk. And thank you to all our audience members for participating so well and so vigorously. Thank you again. We'll see you on March 3rd. Take care.